Hello and welcome to the Hammersmith Hospital. My name is Justin Davies. I'm a
consultant cardiologist here at Imperial College NHS Trust, and it's my pleasure to welcome you to this live from the Hammersmith broadcast. I'm joined in the cath lab today here by Sayan Sen, as a colleague here at Imperial, and many of you of course will be very familiar with the work Sayan's done in the field of coronary physiology. So today we're going to start out on a new venture for us here at Imperial, where we're going to pioneer this concept of live case broadcasts with a different twist. We are going to essentially take on a vendor-neutral broadcast, and we're going to be taking on challenges for the field. Essentially, we're going to be looking at new technology, and we're going to be trying to use this in the cath lab in a real-life situation, but try and frame that in and around the clinical evidence base and try and get all this done in around an hour's time. So the first case we'll take on with this regard is essentially looking at best in practice use of fractional flow reserve and how we can use this to treat triple vessel disease in 2014. And the key words for this presentation will be around fractional flow reserve, physiological guidance and assessment, looking at coronary blood flow, considering the impacts of syntax and the functional syntax, and how may this impact on guidelines. This is the model we're going to apply with these live case transmissions, so it's applying clinical evidence, technical practicalities, and hopefully leading to bring things together to improve clinical outcomes. So let's start by looking at this first case, and indeed the case we're going to be doing today. So this is a gentleman who is 64 years of age. He has a history of exertional angina for the past 6 months, and these symptoms are very similar to his previous acute presentation. Indeed, he presented some while ago with a primary PCI in 2011 and received a stent to the proximal part of his obtuse marginal artery. He's known to have mild LV impairment, and other than these risk factors, he's in generally good health. He's undergone coronary angiography recently, and this demonstrated an unobstructed left main stem, an LAD with some moderate mid-vessel disease, and we'll look a little bit more closely at that in a few seconds, a patent circumflex stent with some atheroma and a mild to moderate lesion in the obtuse marginal. He's also got a moderate lesion in the mid-right coronary artery. So a very interesting case for us to study of a patient with triple vessel disease. And the real question for us here today, and indeed it's a question which we have many days in the cath lab, is how best to handle this patient. Is it best to put multiple stents in? Is it best to send this gentleman to surgery? Or perhaps it's best to assess them physiologically, and indeed that's what we're going to do today. So let's have a look at the angiogram images here. And from these you can see that the obtuse marginal branch on QCA has a stenosis diameter of about 60%, so truly an intermediate lesion. If we then look at the left anterior descending artery, you could see this has a QCA of around 50%. So again, it's an intermediate lesion. And finally, if we look at the right coronary artery in the mid-vessel there, you can again see a stenosis of around 60% diameter. So it's an interesting case, and a case which we'll enjoy to share with you today. And to start off with, we're going to show you how we effectively move ahead in terms of best practice to prepare all the things we need to make good physiological measurements in the cath lab. So the first thing we're going to be doing is looking to ensure that our PA pressure is essentially in a normalized position, so the PA should be zeroed. So the first thing we do to that is we're going to turn the PA pressure off at the tap. Okay, so let's press the 0 PA button now. That'd be fantastic. At the top, that's fantastic. And 0, that's great. And now if we just open the port once again, that's great. So that's the first part, and that's very, very essential to ensure that what we measure, we're measuring of any physiological measurement, is absolutely valid in terms of everything's referenced to true physiological pressures. So the next thing we're going to do is to move on to look at the pressure wire itself, and for that we're using the Aries pressure wire here today. And the first thing I'm going to do to this is to flush the pressure wire just with some saline. There's a port here. I'm just going to flush the pressure wire, as you see me doing this now. And this is to ensure that the sensor becomes activated, and any drift which can happen on any of the pressure wires tends to happen early on, and this can help to avoid that happening. Now the next thing I want to do is, while the pressure wire is seated on the table, is I'm going to connect this, and this connects wirelessly to the Contion system here. So first thing we have to do is to activate the system so it's expecting a connection. And the next thing I do is to just push the little button down, and you can see that the light on this sensor has gone green, that the pressure wire has been recognized, and we're all ready to begin advancing the pressure wire into the artery. Good. So these wires come with a straight tip on them usually. What do you normally like to do in terms of to help guide the wire down into the arteries?
So essentially what I'll do is I'll feed it through my needle introducer and just put a simple bend on it. I think you can make things a little bit too complicated. Just making sure that we don't damage the pressure sensor, which is a little way back from the tip. And I'll just do that for you now.
Okay. So I'm just going to gently withdraw the pressure wire from the packaging and pass that over to Cyan here.
Of course, the tip itself can be moulded into any shape depending on what you predict is going to happen with the vessels. Our vessels aren't too tortuous, so just a simple bend on the wire should do the trick.
Fantastic. So while you're doing that, can I just stop you there? And would the next thing you do before you advance the wire be to give some nitrates?
Absolutely.
And we would do that, and perhaps we could think about nitrates in general and why we give nitrates. Typically, I think you're going to give around 300 micrograms of nitrates. That's where the evidence is. And we do this for a number of reasons, and one is to ensure that we have the largest capacity of the vessel, so to prevent any epicardial spasm. And another reason we do this is to ensure that we don't get any spasm from the wire itself when we advance the wire into the artery. So I'm going to let you carry on and do that, and we can see in this case here today, if you carry, that you're going to take this pressure wire down, and the first thing you're going to do, I imagine, will be to stop with the sensor near the tip of the catheter. Absolutely. And just to normalise.
Absolutely.
Great.
So let's go to our working view, which is our caudal, please.
So while Shai's doing that, if we could perhaps jump ahead to the adenosine slide deck, that would be very helpful. That's great. So yeah, let's have a look. Let's stop there on the normalization. So you're going to effectively pass the wire to the ostium of the guide catheter itself, and park the sensor in a position where it's just sticking out. And here you can see, if we look at the physiology screen, that once you've withdrawn the needle introducer, there's still a slight gap between the PA and PD signals. So I'm rushing you here, and I know you're doing a great job in terms of just trying to that's fantastic. So you're trying to position the sensor so it's just at the ostium of the guiding catheter. That's great. And once we've done that, we will slowly withdraw the needle introducer, and we'll redo the port back up once again. And you can see, as is normal, that it's often that there's a small degree of difference between the mean PA and PD signal. So if I could ask us to, I think, just normalise here, that would be fantastic. And so we're equalising these two pressures. Now, one of the things when we think about equalising pressures is that we're not just effectively looking to make sure those numbers are the same, because it's possible for those numbers to be the same, i.e. a PD-PA ratio of around 1, when we have a lot of damping in the traces itself. So in addition to the absolute pressure ratio that we see there, The other thing we're looking out for is to ensure that we can see all the features of the pressure waveform. And here you can see, we see a nice sharp upstroke, we see a dichrotic notch, and a tail as it falls away. So these are all the features which I'd expect from a high fidelity PA and PD signal. So we can still see it. There's a tiny difference here between the two, the sensor and the transduced signal there. Maybe we should just at this stage take the opportunity to make sure that we re-normalize there. Can we just do that once again? That'd be fantastic. Just takes a second, but it's worthwhile doing. And now you can see that we have very nice normalization. Great. So before you go ahead, I'm just going to move on just to quickly talk about some aspects of the use of adenosine for assessment of coronary physiology. And you can see that we know that we have to use vasodilators to measure FFR. That's a prerequisite of FFR, so it's mandated. And essentially the reason we do that is because we want to stabilize resistance and increase coronary blood flow. And there are loads of different drugs out there which can be used. So we conventionally use at Hammersmith here intravenous adenosine, but many operators use intracoronary adenosine. Some use ATP in parts of Asia, and of course there are a whole range of other agents, papaverine, nicorandil, and other drugs can also be used as well. Now, what's the evidence base for this? Is essentially based on some fairly solid physiology, and here you can see some data from Wilson many years ago now, who essentially showed that even with quite modest doses of adenosine administered, you can get good increases in coronary blood flow. So here you can see at 100 mics per kilogram per minute, you almost get the same response in blood flow as you get as 140 mics of adenosine, and very similar to papaverine. If we then, let's just forward on to some more contemporary work. This is work presented by Bernard de Boer in TCT recently. You can see that a very similar pattern arises here, that with very small doses of intracoronary adenosine, you get the vast majority of the response. So you can see at tiny doses get a big shoot up, and then you can see after about 100 mics of adenosine, this is intracoronary here, there's no further increase in peak velocity. And to many, this is at odds with some of the publications which are out there, which talk about giving higher and higher boluses of adenosine. And you can see in this case here that actually it's not flow which we're affecting when we give bigger doses of adenosine. It may well be that we're manipulating and modulating other aspects of the coronary hemodynamic and systemic hemodynamic circulations. So certainly this is a very nice piece of work which agrees with work from Wilson and Co. and shows that 100 mics per kilogram per minute is pretty much ideal. So, Shai, if I can ask you to proceed here. So we're going to measure the obtuse marginal first, is that correct?
Absolutely.
Yeah.
Just passing the wire down. So Justin, where do you normally put your pressure sensor on these wires in relation to the lesion? So
that's a good question. So I take my guidance from physiology, and we know from the coronary flow dynamics models that when you have a stenosis, distal to the stenosis there's turbulence, and turbulence generates jets which are of higher velocity and sometimes chaotic jets which are lower velocity, but we really want to make sure that we steer clear from these. So the recommendation which comes from the fluid dynamicists is to ensure that your sensor is positioned 2 to 3 diameter widths beyond the stenosis itself. So here it's going to be, I don't know, 8 to 10 millimeters, I'd imagine, in this vessel. Okay, so talk me through what you've done there, Shai.
So essentially all I've done is, if I use the torquer, these wires are slightly stiffer than normal angioplasty wires, and I've used the torquer to just pass the wire down a relatively straightforward vessel. And now I think the region of interest we're concerned with is in that proximal third of the vessel. So I'm distal to that, and I'm happy I'm in a relatively disease-free segment, and I'm happy to make my measurements in this position.
So there's that area in the mid-vessel where you've got more disease. You know, there may be area in more other areas which are, you know, atheromatous as well, but this is where we're focusing in on today, because we know that these more proximal lesions carry a higher prognostic significance for treatment. So are you happy here to begin the infusion of adenosine?
Yeah, I think so. I'm still looking at my PA trace. There's a good notch there.
Yeah.
And we're happy to be starting that adenosine infusion.
Okay. So if we can start the adenosine infusion. As I said, today we're using an adenosine infusion of 140 mics per kilogram per minute, and that's going into the central femoral vein. And let's start that infusion now. Yes,
Yes,
please.
please.
Thank you. We'll start then, and we'll also start the recording. Thank you very much, Mark. So we're watching the adenosine infusion go in here now, and of course this is something which many of us do day in, day out as part of our normal clinical practice. But often we get a situation whereby we have changes in the physiology which occur as we begin our infusion. We know that from studies such as FAME that what the operators did there, the investigators did very meticulously, is administered intravenous adenosine, and then they waited for a period of stable hyperemia. And we know that this is important. There have been several publications over the last few years which have shown that if you don't do that, then you can sometimes get results which differ between peak and stable hyperemia. And perhaps this study here from Tarkin et al. Demonstrates this nicely. This is a case where you can see the baseline FFR value, or this is the resting PDPA is 0.92. The values fall very rapidly down to 0.75 before stabilizing, and then you can clearly see it stabilizes beautifully at around 0.84. So this is an interesting case. You can see it goes to the 0.75 threshold, which of course is an important number for FFR. It then rises above 0.8 and then becomes very, very stable in this setting. So, Shai, what have we got? What's been happening?
So
here?
we've been infusing adenosine now for a minute and a half.
Okay.
Our FFR value has dropped to 0.6, so indicating a significantly ischemic lesion. And I think we're stable at this stage. We often go for about 2 minutes to make sure that we've reached stable hyperemia, and that's certainly borne out in the studies that have examined FFR.
But I think
we're stable now.
I agree, and I think in this case we can be pretty happy that we're stable. So I think we're safe to stop the adenosine infusion, and we can stop the recording. That's fantastic. So you can see, if we look at the physiology, you can see that there's a nice separation of the traces, and then you can see there's a low value in the FFR here of somewhere between 0.61 and it maybe dropped down to 0.85. And I don't think in this particular case there's this question of whether it's dropped down and then come back up.
No.
It's really miles beyond the range of doubt here. And perhaps if we zoom out on the physiology screen there completely, we can see the beautiful physiological response that we got. And this is very typical of a good adenosine response. Yeah. So we feel pretty confident in this setting that this result is genuine. It's below both the 0.8 and 0.75 cut points, so I think this is fairly indicative that this lesion is very likely to be causing a reduction in blood flow, and from the data we have, that it's likely to benefit from stenting.
Absolutely.
Yeah. Yeah. So what I'm going to do now is, while Shai's moving ahead to doing the marginal branch, I'm going to just talk you through some of the data with regards to the physiology that we have out there, and particularly with regards to the evidence that we have for using FFR, and why I think this is increasingly very, very important, particularly with the changing guidelines that we have from the recent ESC consensus documents. So we can see, if we look at the slide deck here, I'll just wait for those to come up. That I believe that every physician should be routinely using FFR or a pressure wear assessment in the cath lab in 2014. And what I base this consensus decision on? Well, I think that, as I've said to you, that I think there's a hell of a lot of evidence to support the use of FFR in the cath lab. And if we can have the next slide, that would be super. Next slide, please. And we know that this evidence is founded on the fact that angiography alone is a very, very poor surrogate for physiology. So you can see here, if we have an X-ray taken, and we fire the beams at the X-ray towards the artery, that in one view you can see that the artery looks very, very severely diseased, and in another view that the artery here looks very mild. Now, perhaps an alternative way of looking at this would be at this 3D OCT reconstruction. If we play that, so you can see this is both a 3D OCT reconstruction of the angiography, but also the OCT image, and you can see that how one could be confident enough to assess an MLA or a stenosis diameter from such an undulating terrain as you can see here is very, very doubtful. All of these aspects are influencing blood flow and influencing the pressures that we measure in the coronary artery. And really this is borne out in the next slide, which you can see, if we move to the next slide, that would be great, that two stenoses of identical MLA, but different structure. You can see the first one is very smooth and the next one is very severe. Although they have the same MLA, they have very, very different physiological properties. The top one has virtually no pressure loss and a lot of pressure recovery, and the bottom has a lot of pressure loss. So in practice this means the top one would give you an FFR which is very normal, and the bottom would give you an FFR which is likely to be very significant. So moving on now, you can see that even when we do very, very rigorous assessments, and these were some lovely studies done, large studies using intravascular ultrasound and FFR, you can see that FFR values can be significant or non-significant over a wide range of different MLAs. So moving ahead now, we can see that we have this picture of an importance of the physiology. We know that anatomy can't tell us everything, and we know that the aspect of physiology which is key and most important is the coronary blood flow. And here you can see a beautiful image of blood flowing through these small vessels. And although we try and measure all these surrogates, whatever surrogates you want to measure, we know ultimately that the thing which we really want to measure is blood flow. Now, of course, the reason we can't measure flow routinely, and many of us do, but from a research perspective, is that flow is hard and challenging to record. Whatever modality you're using, whether it's thermodilution or whether it's using Doppler, it is challenging. And here you can see, this is a lovely illustration from one of my colleagues, which shows initially there's a poor Doppler flow recording, and then you can see this latter half, or latter third of the trace is a good Doppler flow recording. Whilst if you look at the top, you can see throughout the entire recording the pressure traces look to be very good. And indeed this is precisely the reason why pressure was used as a surrogate for flow in most of the physiology that we use today in the cath lab. So to set this in a historical context, you know that Grunzig was obviously a pioneer of coronary stenting and PCI. He of course was also very interested in physiology, and you know that even though the early tools he had were very limited and they were very large in comparison to the beautiful pressure wire tools we have today, he was in there making these measurements very, very early on. Now, of course, since then, pioneering and foundation work has been done using these smaller and smaller sensors to lead us to where we are today. And most of this work was done, of course, by Nico Pils and Bernard de Bruyne, who made the foundation for fractional flow reserve. And this has really evolved over the last 20 years to be in a position now where there's an important place in guidelines, and indeed the very reason we're in the cath lab today in terms of routine clinical practice. So things really have changed. If we look back at when stenting was really the only way to go, so this was a really an oculostenotic driven specialty that we all worked in, the very concept that you could be choosing which lesions to stent based on a physiology was pretty alien. And indeed many of the authors involved in these first pioneering works, such as the DEFER study, had many battles to fight. So this is essentially firstly showing that a lesion which looks significant you could safely leave alone by using a pressure wire to guide your therapy. And of course we take this for granted now. We know the data from the DEFER study, which was one of the important foundation studies, which showed us essentially that whether you defer a lesion or you treat the lesion, you can have safe clinical outcomes. And certainly these are both much better than if you just blindly go ahead and treat significant lesions. Now, I said this was very much the foundation, and moving ahead from there, the real question was, could physiology be used to improve PCI? And this was the concept behind the FAME study, of course, a much larger study, much more international randomized clinical trial, which essentially took patients with significant coronary disease, much in the way as we've got today, so more than 50% stenosis in more than 2 or 3 vessels, and then essentially randomised to either using angio guidance alone or using an FFR guided strategy, and in this case using an FFR threshold of less than 0.80. Now, of course, the results of these studies we all know. We've integrated this practice into our general use in the cath lab, and probably the most striking results, of course, all of these results here you can see whether it's MACE, TVR, death and MI or MI on its own, all there's a difference, a graphical difference between the angio-guided arm and the FFR guided arm alone, but certainly you can see significant differences between the MI group and the death and MI group. So essentially this data points towards the fact that if you use FFR guided therapy, so pressure wire guided therapy, it gives you improved outcomes over just blindly going in and putting stents in where your eye will tell you to do so. So it's the next step in the evolution of this treatment. Now at around that same time, we know that the COURAGE study was underway and was reporting. And this study showed us something slightly different, but it showed us that perhaps PCI on its own was not much better than medical therapy. And you can see here we've got long-term follow-up from the COURAGE study, which reports to this. Of course, we know since then there's been a lot of findings have come out around this study suggesting that perhaps patients crossed over arms, lesions weren't significant enough, which has led us essentially to where we are today with regards to planning for the next tranche of studies. So before we go on to those last two slides, I'm just going to go back to Shai and see where you've got onto with regard to this case.
So what I've done is after our measurement, come back to the osteum, make sure there hasn't been a drift on the wire, which there wasn't, and we re-equalise at that point. Now pass the wire distal into that vessel, and we're ready to start with our adenosine again, please.
Okay, so you renormalised, yeah,
absolutely,
and so you're happy there's no drift there. You've advanced the wire, you're well distal in that vessel. So Mark, if we could start recording, that'd be fantastic. So the baseline value here is pretty normal, yeah, so it's 0.99. The mean pressures look reasonable. We know we have to be cautious when the mean pressures drop a lot, and certainly less than 60 or 70 for a PA pressure, but here you can see that that really isn't the case. And we're just beginning now to infuse our adenosine at the same dose.
Absolutely the same dose.
And we're looking to see if there is any physiological need here which would suggest that this patient would benefit from a stent in this vessel as well.
Absolutely.
So now the first thing you can see here is you can see there's a little bit of ectopy, and you can see there's a little bit more separation of the pressure curves. And perhaps this is our first inclination that some of the adenosine's being infused into the patient. How are you giving the adenosine today?
So we're giving it intravenously through a 6-French sheath in the femoral vein.
Okay.
I have a question for you, Justin.
Yeah.
How often do you increase the dose? Do you stay at 140 mics per kg per minute and take that as your result of FFR, or do you often go up to 180?
Okay. Well, that's a good question. And really we presented that data from numerous physiologists from over the last 30 years, which really fall back to flow. And you can see that even with quite modest doses of adenosine, that flow increases significantly. And when you get certainly to doses of 140 mics per kilogram per minute of intravenous adenosine, then actually flow in almost all cases is maximized. Now what you do if you push the adenosine dose even higher, certainly intravenously, is you can start to knock your PA pressures down. And if you knock your PA pressures down, the coronary microcirculation can start to go into a chaotic state sometimes, and this can lead to alterations in this PD-PA ratio, which can sometimes be confusing. So I think we need to be very cautious there, and then of course that's in addition to the nasty side effects that some people feel. So we've been running now for
almost 2 minutes now, and I think we're very stable, so I think we can just stop there.
We can stop the adenosine, and let's review this trace once again here. So thank you for stopping the adenosine. That's great, thanks Mark. That's superb. So we can see here again, if we look through this trace, for a start we can see that it's a very nice recording. Okay, so you haven't got lots of artifact, you haven't got loads of extra beats, pressure traces going up and down, which you sometimes get. So you can have confidence in your data here. You can see that initially the difference between the PA and PD pressure was very small, the ratio is small. Then you can see there's a period there when the adenosine starts to become infused, perhaps a little bit of ectopy or a small pause, and then you had separation of the curves, which then was remarkably stable for a long period of time. And here you can see that we've got an FFR value, the lowest value of about 0.91 at 1 minute 20, but I'm pretty certain that anywhere from a minute to when we stopped, you would get a value very, very close to that. Now, sometimes, of course, we have some doubt if the FFR value is close maybe to a cut point, 0.81 or 0.76, that it could easily move in either direction. And of course, in that way, FFR is just like measuring blood pressure in the clinic. So you have to obviously use clinical judgment in those cases. But I think when you have an FFR value of 0.91, I think we can be, again, pretty certain that this lesion is likely to be non-significant. So how do you square this? Because the QCA for the LAD was 50%. The QCA for the marginal was 60%. Absolutely. So what does this tell us?
Well, it just tells me that anatomy really can't be used as a surrogate of physiology. And I think we're missing a lot of information just by looking at different angiographic views. Of course, the hemodynamics of stenosis is extremely complex. And what we get with a pressure wire is a summation of all those complexities in one number, which is fantastic. But we just don't get that with an angiogram.
Yeah. So it's rather like that QCA or 3D QCA OCT reconstruction we saw earlier. It's very easy for us by eye in the cath lab to pick up on a certain focal stenosis, and we target all our energy at either diagnosing and treating that. And really what that fails to do is to take into account all the disease along the length of the vessel. And that's the beautiful thing that the pressure wire does. Essentially, you push the wire down, essentially it accounts for all of that atheroma, all of those stenoses along the whole course of the vessel, and it gives you a single number to help address that question. Now, of course, sometimes when you have got diffuse atheroma, it may be that the stenosis which is causing the most problem is not the one which you think it is. And in those cases, that's when we'd want to perform a pressure wire pullback,
Yeah, absolutely. So if we have diffuse disease, that's often where I would do a pressure wire pullback.
Yeah.
But I think here the disease is quite focal in that OM, so I'm happy with our measurement.
Yeah, so I think that's a very good point. So if you have diffuse disease and you have a value, or the FFR value, which is significant, that's the case when you may want to use a pressure wire pullback. If your FFR value is above these threshold values, doing a pressure wire pullback is likely to not give you any really additional significant information.
Absolutely.
Yeah. So here we've already taken this case. You've got on the left system here, you've got the OM disease and you've got the LAD disease. Now clearly, it's very likely in this case that the LAD disease is causing this patient's symptoms. We're still going to move ahead and perhaps, if there's time, look at the right coronary artery as well. But it's interesting to note this gentleman came in with a primary PCI some time ago, a few years ago now, had the circumflex artery stented, obviously gave him good relief of his symptoms. But it's possible at that time that he also may have had disease in the left anterior descending artery as well. So it's entirely possible, isn't it?
Yeah, absolutely.
So, and of course, routinely now we don't assess the coronary arteries, but there's evidence building from some of the studies which have come out recently to suggest maybe treatment. And of course, we know that other studies are underway which are essentially using pressure wire in the acute non-corporate vessels to assess this as well.
Yeah, absolutely.
Okay. Great. So we've got a question which has come through, and it asks about normalization and whether we normally normalize with contrast or saline in the line. Now, what we tend to try and do in most of the studies is to try and advocate using saline normalization, certainly for very physiological studies. But one of the elements of research we've done on the benchtop here is to look very, very closely at the effect this actually has on the pressure signals. Now, one thing you can see quite clearly from the traces we're looking at the moment on the FFR system is that despite the line being filled with contrast, you can see that we can see both a beautiful notch in the PA and PED pressures. So this suggests that we don't have any damping here, and suggests that we've got a signal which is truly representative of the underlying physiology. So what I'm going to do now is I'm just going to carry on just talking in general terms around the FFR evidence base, and I'm building towards where we're going now with these tools. And I'm going to, whilst I do this, I'm going to let Shai proceed with the right coronary artery. Now, the right coronary artery here is a slightly tricky artery. The guide catheter tends to want to dive in, so it may be the case where Shai will use a buddy guide wire to help position and hold the guide wire in place to enable pressure wire measurements to be made without damping of the actual signal. So if we can just flick back to the slides, that's great. And this is where we got to, really. We know that the Courage study showed that there was essentially no difference between PCI and medical therapy. And we know that FAME showed that PCI and when you didn't use physiology and PCI when you did use physiology, there was a big difference. So it really did favour physiological guided therapy. So if we can go back to the first of the FAME2 slides here, this study really went to tackle essentially head on the Courage type study, when essentially it's asking the question is, if we take people with physiologically significant stenoses, we randomise them to 1-to-1 to either receiving PCI plus medical therapy or medical therapy alone, which group of patients essentially does well. So do people who have got genuine flow limitation measured using the FFR technique, do these patients benefit over just blindly treating people with medical therapy and essentially leaving them alone, as Courage may have suggested? And as you all know, the results from these studies, and this was the most recent results which are available in the New England Journal, the 2-year follow-up, really extend the findings that were reported initially at 1 year. So you can see that the cumulative incidence of events, in terms of here it's mainly revascularization driven, is considerably higher, much higher in the medical therapy arm when compared to the FFR guided PCI arm. Importantly, you can also see the death and MI is higher now in the medical therapy arm when compared to the PCI arm. So one thing about FAME2, it's a great study. It's very brave to do these studies, but you do, as a physiological investigator, open yourself up for criticism, and it's been criticised to some extent as some aspects of blinding, and that some of the endpoints were perhaps soft with revascularization. Well, I think with these new results which have come out, and certainly the added data which is available in the publication, it's quite clear that although, of course, revascularization happens because patients do get chest pain, many of the events here are being driven by troponin rises, by being driven by ST segment changes, and as you can see here, myocardial infarction and death. So where are we going essentially now? Well, for me, this is perhaps one of the most interesting and perhaps worrying documents which came out at ESC. Essentially, this is the guidelines for treating and revascularizing cases, just like we had today, so triple vessel disease case. And essentially, what these guidelines say is that surgery is better in almost every case. So you can see whether your syntax score is low, medium, or high, surgery prevails really here. And with the exception of the very low syntax score, so less than or equal to 22, surgery it should be your first bet in terms of the first thing we go for. And this, of course, has led to a whole range of other studies which are underway. So we can show the first of these, the Syntax 2 study. And this is a study which is looking at triple vessel disease using physiological assessment. Here it's using the hybrid IFR-FFR approach. It's identifying patients who have physiologically significant lesions, and if they do, treating them with modern drug-eluting stents and optimizing them with IVUS guidance. So essentially giving the patients the best stents and the best chance by ensuring that the stents are appropriately deployed. Now, you'll see the other part of that flowchart in the Syntax 2 study is essentially that patients who have a physiological result which is negative are left well alone. Okay, so often this means you're leaving patients alone who apparently have significant angiographic disease. It may be disturbing. The operators may feel uncomfortable, so often the surgeons may be uncomfortable, but we know that the evidence, certainly in terms of FAME and FAME2, is very supportive of this approach. So this is Syntax 2. There's another study which is underway, which is the FAME3 study. And again, this has got a very similar design, again using a physiological guidance to assess and to isolate the people who have physiological stenosis who would benefit from revascularization. But in this study, rather than having a historical surgical control group, as is the case in Syntax 2 study, there's a cabbage group as well. So both of these studies are very, very interesting studies. They've both got potential to shape the field in front of us, and really this is essentially what we're doing today in the cath lab. If we look at those European Society guidelines, you can see that these studies, above and beyond being interesting and important for our care, are essential because the guidelines at the moment are pushing us down a different direction. They're pushing us down the direction of saying that these patients should be going to surgery in almost all cases. Now, I'm sure many of you who are performing triple vessel disease physiological assessments on a routine basis will be very, very aware that often the case, maybe we'll find this today, that the cases which look angiographically severe 3-vessel disease often translate into very simple 1 or perhaps 2-vessel disease. And often you may pass the pressure wire down a different vessel and find out another artery was perhaps important as well. So I think that's really the state of play where we are in terms of with the clinical evidence and the trial data today. And now I'm going to rejoin Shai, who I can see has got the guide catheter into the right coronary artery. You've passed a BMWR. Yep. Okay.
Situation so we can normalise and be comfortable that we've normalised properly with aortic pressure. All I'm going to do is pass a BMW wire down there and back the guide catheter out. So the last still there is the guide catheter backed out well into the aorta, so we've got good aortic pressure with a good aortic notch.
Okay, so this is a very good approach. So often you'll find that you have cases where the PA signal and then of course the wire pressure when the wire goes in as well are exceedingly damped. And if you try and make a physiological measurement under those conditions, you are likely to get an errant and abnormal result, which doesn't truly reflect the underlying stenosis, and therefore you could be doing the wrong thing for your patient. So sometimes it's possible to get the guide catheter in, advance your pressure wire, then back the guiding catheter out or twist it slightly. In this case, we were having quite severe damping as a result of the guide catheter diving in. I don't think there's a particular osteal stenosis there. The guide catheter was diving in, and Shai chose here, I think very sensibly, to use a buddy guide wire to act as a support to enable us to normalise the pressure wire appropriately, and then to advance the pressure wire in beyond the stenosis to enable us to get a physiological measure. So you can see now the buddy wire is doing such a good job, essentially, that actually he's able to hang the guiding catheter at a considerable distance, and actually so far that the pressure wire is not finding the ostium of the vessel. Of course, if this ever happens, it's possible just to advance the guiding catheter in a little bit, and then to essentially advance the wire through once you've repositioned your guiding catheter. Okay, so as I say, these cases can be challenging, and perhaps while I was just doing that, I'm just going to carry on and just talk a little bit more around where we are with physiology, and then essentially look at how the recent clinical data which we have kind of plays into this a little bit more. So we certainly know if we look at physiological adoption in the diagnostic setting, that adoption is very limited. And this is data, percentage of fractional flow reserve used from 2013 to 2014. And you can see here that almost all of these numbers are very, very low, single digit, and almost all, the exception of the United States, very, very low indeed. Now, of course, these numbers are lower than what we're normally presented with, because we're normally presented with numbers which show cases where FFR is used at all, and that's often around question around PCI. So it's where people have already made a kind of judgment. And here you can see in the kind of purely diagnostic setting, the use of the physiology is very, very low. Now it does differ by territory, and in Europe it varies according to the different parts of Europe, and of course in Asia it varies according to the different parts of Asia as well. But we know, and the next slide show essentially that there's a rich evidence base here for using physiology. We've seen how the studies are doing it, but if we can perhaps move on to essentially some of the future aspects of using this technique, we can see that triple vessel disease assessment is becoming increasingly important, and the use of the functional syntax score is vital in hopefully increasing the use of physiology and PCI in the cath lab, and enabling us to do more and perhaps not refer as many patients to surgery. So I'm just going to hand back now to Shai. So it looks like we've got the pressure wire into the vessel, and you look like you've lined it up so the ostium of the
challenging case. All I've done here is use the BMW to give me more support to my guide, and now I'm happy that we've got a very nice notch on that aortic trace. So the radiolucent wire there along the vessel is the BMW wire, and you can see the pressure wire at the proximal end of the vessel. So I'm happy here to normalise, Justin.
Now, so this is one situation where you're benefiting here from the buddy wire. Is that right? So effectively, if the buddy wire wasn't there, you'd be expecting to see a PA signal which was very damped, and you'd be expecting to lose the dichrotic notch and perhaps losing that sharp systolic upstrain. You can see from the traces we have here, and you're just withdrawing the needle introducer now, that we can see, and you see that the PA pressure appears to be very, very dynamic, and you appear to have a nice sharp systolic and dichrotic notch as well. That's great. So you're just withdrawing your catheter there slightly. That's great. So this is again the situation.
This is the advantage of having that body wire. Yep. So the guide catheter is getting sucked into this vessel.
So it's a great case this to illustrate real-world problems that we have. So there's a nice solution here. So what I'm going to do is I'm going to keep moving here, because the last thing you want is for us to be talking for ages. Once you've removed the needle introducer, let me know, and then what we'll do is we'll recheck our normalisation here once again. Okay, so if we can do that now, that'll be fantastic. So again, we've just always check normalisation at the beginning of the case, just to ensure. Now something funny's just happened there. I think your guide catheter's probably just dived in a little bit more, but I think we had normalised before that. So I'm happy for you to carry on advancing your pressure wire, and as you do, you'll probably find you'll get a little bit more support, and the guide catheter will be able to just be pulled back. So you're going through, just traversing the stenosis there, and maybe just a little bit of talking on the guide catheter may help here, just to give us a little bit more of pressure. That's good job, great.
Good.
So Shai's just going to manipulate the and just gently torque this pressure wire here through the stenosis and down into the main channel of the right coronary artery. Now we often see cases here whereby operators don't fully appreciate the effects of the damping, and that can really lead to some rather errant results, and certainly can cause physiological results which don't fit with the flow-related patterns that we'd expect in these cases. So you've got a very nice setup now. You can see the guide catheter's out, you've got the wire down, you've given some nitrates before everything went in, which is great, and essentially now we've got a resting value which looks stable. We've got nice dynamic traces there, so perhaps if we can start the adenosine and if we could start the recording as well, that would be superb.
So JD, any problems leaving that BMW wire in?
Well, I think, can you start the adenosine? That'd be fantastic. I think that if we had a situation whereby we had a lesion which was physiologically very, very borderline, then we may have some concern, and that may be the case. You know, we don't know in this scenario. It's highly likely with that resting ratio that this case would be completely negative. But let's see. We'll essentially run the adenosine, and we'll see what result we get in this case. If it is borderline, then we need to take that into consideration.
Absolutely.
I would be very, very cautious here to pull that wire back, though, because I think that what you may find is that if you do, everything comes back. And we've all experienced situations like that before, which are uncomfortable when we lose wire and catheter position in the catheter lab. So again, we're looking at our traces here. We can now see, because we're using this femoral approach, that the administration of adenosine is relatively easy and relatively rapid, and we have more confidence using this approach that when we see a physiological response that is actually genuine. Now what I mean by that is often if we're administering via a very small cannula in the forearm or the wrist, which really shouldn't do, then often the response can take a long time, and in that setting we need to sometimes give higher doses of adenosine.
Absolutely.
So we've been running for 1 minute and 10 seconds here. What are your feelings here now?
So I suspect we've reached stable hyperemia. I'm happy to go on for a few more seconds. But I suppose we've gone from a 3-vessel angiographic patient down to a single vessel.
Yeah.
And really, what's your experience in how these kind of measurements have affected heart team discussions?
Well, it's very, very interesting, and perhaps we could stop the adenosine now. I can see he's getting a little uncomfortable here. We know with the heart team, often cardiologists are increasingly educated. They know when lesions are needing interrogation with physiology. They know that the physiology will often change the results of their assessment. Our surgical colleagues are perhaps just on the learning curve here with regards to using physiology or requesting physiology routinely, and we know that this can sometimes cause some discord in these meetings where surgeons are absolutely convinced that the lesion is significant, whereas the cardiologists are perhaps more reserved. So they want to examine, physiologically explore lesions to confirm that the lesion is significant prior to just going ahead and deploying a stent. So I've been asked, there's a question which has come up from some of the audience, does adenosine hyperemia have the same effect in everyone? And of course, just like every drug, the answer to that, of course, has got to be no. We know that there are various studies which have shown that it's possible to modulate the effects of adenosine by various drugs. We know that you can either increase or decrease flow, and indeed we often take precautions for this, so often asking our patients not to drink caffeine for 24 hours before they come into the cath lab for measurements of fractional flow reserve to be made. So I think with all of these things, the key point here is just to be very, very switched on in the cath lab, and we're essentially looking for a physiological response. So when you administer the adenosine, do you see a drop in blood pressure? Do you sometimes see a small pause? Does the patient describe any symptoms? And if they do, then you can be fairly confident the patient has had the adenosine getting to them centrally. If, however, you don't see any response at all, that's when I'd be certainly more anxious, and I'd certainly want to make sure that the adenosine was arriving promptly and appropriately to the patient. So I think we've got about 4 or 5 minutes left. I'm just going to finish off with regards to highlighting how syntax and the functional syntax is really changing the way we practice. We've seen FAME2, we've seen FAME3 and Syntax 2, which are all studies which are looking to essentially apply what we've done today in the cath lab, but in routine clinical practice. And you can see from this very nice paper from Namadal, showing that it's possible to almost double the number of cases using a functional syntax score who have a low syntax score. Remember that low syntax score are the patients who there's very little question will benefit from PCI. So the surgeons and the cardiologists' battle there is very, very minimal. So if we can do that, shift more people away from complex procedures into simpler procedures, it perhaps will lead to better outcomes. And this can often turn cases from 3-vessel disease to 2-vessel disease, 3-vessel disease into 1-vessel PCI, and very rarely can turn cases from 3-vessel disease to no PCI needed at all. And perhaps a nice study which looked at this was that from Eric Van Bell and the French investigators, large study published earlier this year in Circulation. And essentially what they did is they looked at medical PCI and CABG diagnoses, which were essentially made prior to the physiological measurements being made. So the investigators say, what would you do with this patient? Some said they put in a medical treatment, some PCI and some CABG. You can see that along the bottom of this graph here. And then what they did is they measured the physiology, and then they said, well, in the knowledge of physiology, where would we position these patients? Now, what's remarkable is to see that in 7% of patients who originally designated to be CABG were then moved to the bypass arm. 26, again, medical therapy, will move to the PCI arm. And you can see with both the PCI and CABG groups, similar movements. So it appears that when we're using physiology to guide us, it really does change the strategy that we use in the cardiac catheter lab. And the next slide really shows you that it's essentially safe to do this. So you can see the green and red lines show that if patients were reclassified or not reclassified, that the survival free from MACE is very, very similar. But to me, what is very striking, and I'm sure that this is somewhat underpowered in the context of the entire study, is the survival free from MACE and how much worse this is when we're using physiology and we just choose to disregard it. And you could argue that the green and red lines there are very, very similar. They're almost upon one another. But what you can see is when physicians just take this old-style approach, they take an approach of just using an oculostenotic reflex to guide revascularization, and they disregard physiology, you can see that the outcomes for our patients are considerably worse. So moving ahead now, you can see, and we spoke momentarily about surgery, and really I think that this is an area which is ripe for further interest for both cardiologists and surgeons. And you can see from this nice paper from Botman that essentially if we look at where grafts are occluded, and this is early graft occlusion, that essentially if a lesion is physiologically significant, there's almost invariably very low rates of graft occlusion. But as the lesions become more significant, then this graft occlusion increases steadily. And you can see if we overlay the FAME2 event results, they're a mirror opposite. So you can see if we leave patients with physiologically significant lesions untreated in FAME, they do very badly. But those same patients, of course, have a lot of requirement for additional blood, and they're also the patients who do very, very well for grafting. So perhaps a message for today is not purely one of physiology for cardiologists, but it's really a question of working more hand in hand with our surgeons. We know, and we've seen today, a case of apparent 3-vessel disease got converted into a single-vessel disease, and there must be countless cases in heart tone meetings throughout the country and throughout the world where this happens, where you have discussions between cardiologists and surgeons all debating on the basis of an angiogram the best strategy for their patients. And clearly you can see that there's no way that we can really know this for certain. So Shai, what are we planning to do with this case now?
Well, I think he's got a long segment of LAD disease. He's got mildly impaired LV function. He's got good symptoms. I think we'll discuss the best options in terms of a limited lemur to his LAD, or just put some stents in, really. Okay, so but now we've got justification here to put the stents in, and we know that it's very likely if we stent that area, because it's a big physiological drop there, we're going to get a nice step up in physiology. Absolutely. Which will likely lead to an improvement in his symptoms. And most importantly, 5 or 10 years ago, this patient may have ended up having stents in the marginal branch and the right coronary artery, so complete revascularization, and for no benefit whatsoever. In fact, you could argue that it's at a risk and a cost, both in terms of financial for the trusts, but also a cost for the patient, because of course there's acute complication rate, and then there's both medium-term complications and longer-term complications associated with restenosis. So I'm just going to summarise the case, going through all the points we've looked at today. We believe that there's strong evidence for the use of physiology in the cath lab, and we know that measuring pressure, it's not always perfect, but it provides a very convenient and direct or indirect way of measuring blood flow in the lab. And we know from all the studies which have been done to date, this is highly predictive of patients who are likely to benefit from PCI, and also it shows us who is safe to defer from PCI. Moving on, we know that we're under pressure as cardiologists to use these tools more and more, and I believe that's entirely appropriate, and I believe that it's only by using these tools that we can essentially isolate the lesions which would truly benefit, reduce case complexity, and hopefully, and most importantly, improve patient outcomes. So I'm going to wrap up there. I'm going to say thank you to Shai for performing this case so adequately. I'm going to say thank you to Suk Nidja and Rasha Alami for preparing the case. I want to thank you for the rest of our team here in the cath lab today for working alongside us to make this such a success. And I'll say thank you to you for tuning in. This is the first of a series of Live from the Hammersmith broadcasts we're going to be doing. These are not going to be all physiology. They're going to be a whole host of different aspects of cardiology, ranging from pacing to valvular disease, looking at ASD and PFO closure, and all of the modern devices and techniques as they evolve throughout the next few years. I thank you very much for watching, and I hope you enjoyed this live case demonstration.